Respiratory failure. The term respiratory failure is used when pulmonary gas exchange fails to maintain normal arterial oxygen and carbon dioxide levels. Its classification into types 1 and 2 is defined by the absence or presence of hypercapnia, raised partial pressure of arterial carbon dioxide. Pathophysiology. When disease impairs ventilation of part of a lung, example in asthma or pneumonia, perfusion of that region results in hypoxia and carbon dioxide-laden blood entering the pulmonary veins. Increased ventilation of neighboring regions of normal lung can increase carbon dioxide excretion, correcting arterial carbon dioxide to normal, but cannot augment oxygen uptake because the hemoglobin flowing through these normal regions is already fully saturated. Admixture of blood from the underventilated and normal regions thus results in hypoxia with normocapnia, which is called type 1 respiratory failure. Diseases causing this include all those that impair ventilation locally with sparing of other regions. Arterial hypoxia with hypercapnia type 2 respiratory failure is seen in conditions that cause generalized severe ventilation perfusion mismatch, leaving insufficient normal lung to correct partial pressure of arterial carbon dioxide, or any disease that reduces total ventilation. The latter includes not just diseases of the lung but also disorders affecting any part of the neuromuscular mechanism of ventilation. Now, management of acute respiratory failure. Prompt diagnosis and management of the underlying cause is crucial. In type 1 respiratory failure, high concentrations of oxygen, 40 to 60% by mask, will usually relieve hypoxia by increasing the alveolar partial pressure of oxygen in poorly ventilated lung units. Occasionally, however, in severe pneumonia affecting several lobes, mechanical ventilation may be needed to relieve hypoxia. Patients who need high concentrations of oxygen for more than a few hours should receive humidified oxygen. How to interpret blood gas abnormalities in respiratory failure? Type 1 and type 2 respiratory failure. Type 1 is called when hypoxia, partial pressure of arterial oxygen is less than 8 kPa or 60 mm mercury, and normal or low partial pressure of arterial carbon dioxide, that is less than or equal to 6 kPa or 45 mm mercury. In type 2 respiratory failure, hypoxia is presence, that is partial pressure of arterial oxygen less than 8 kPa or 60 mm mercury, and raised partial pressure of arterial carbon dioxide, that is more than 6 kPa or 45 mm mercury. In type 1, in acute case, acute type 1 respiratory failure, hydrogen ion normal, bicarbonate normal. Causes are acute asthma, pulmonary edema, pneumonia, lobar collapse, pneumothorax, pulmonary embolus, ARDS. Chronic type 1 respiratory failure includes COPD, lung fibrosis, lymphangitic carcinomatosis, right to left shunts. In acute type 2 respiratory failure, hydrogen ion increases, bicarbonate is normal. The causes are acute severe asthma, acute exacerbation of COPD, upper airway obstruction, acute neuropathies or paralysis, narcotic drugs, primary alveolar hypoventilation, failed chest injury. In chronic type 2 respiratory failure, hydrogen ion is normal or increased, bicarbonate ion is increased. Causes are COPD, sleep apnea, kyphoscoliosis, myopathies or muscular dystrophy, ankylosing spondylitis. Acute type 2 respiratory failure is an emergency requiring immediate intervention. It is useful to distinguish between patients with high ventilatory drive, rapid respiratory rate, and accessory muscle recruitment who cannot move sufficient air and those with reduced or inadequate respiratory effort. In the former, particularly if inspiratory stridor is present, acute upper airway obstruction from foreign body inhalation or laryngeal obstruction, that is angioedema, carcinoma, or vocal cord paralysis must be considered, as the Heimlich maneuver, immediate intubation, or emergency tracheostomy may be life-saving. More commonly, the problem is in the lungs, with severe generalized bronchial obstruction from COPD or asthma, acute respiratory distress syndrome arising from a variety of insults, or occasionally tension pneumothorax. In all such cases, high concentration, example 60% oxygen, should be administered, pending a rapid examination of the respiratory system and measurement of arterial blood gases. Patients with the trachea deviated away from a silent and resonant hemithorax are likely to have tension pneumothorax, and air should be aspirated from the pleural space and a chest drain inserted as soon as possible. Patients with generalized wheeze, scanty breath sounds bilaterally, or a history of asthma or COPD should be treated with salbutamol 2.5 mg nebulized with oxygen. Repeated until bronchospasm is relieved. Failure to respond to initial treatment, declining conscious level, and worsening respiratory acidosis, that is hydrogen ion more than 50 nanomole per liter or pH less than 7.3. Partial pressure of arterial carbon dioxide more than 6.6 kilopascal or 50 mm mercury on blood gases are all indications that supported ventilation is required. A small percentage of patients with severe chronic COPD and type 2 respiratory failure develop abnormal tolerance to raised partial pressure of arterial carbon dioxide and may become dependent on hypoxic drive to breathe. In these patients, only lower concentrations of oxygen, that is 24 to 28% by Venturi mask, should be used to avoid precipitating worsening respiratory depression. In all cases, regular monitoring of arterial blood gases is important to assess progress. Patients with acute type 2 respiratory failure who have reduced drive or conscious level may be suffering from sedative poisoning, carbon dioxide narcosis, or a primary failure of neurological drive, example following intracerebral hemorrhage or head injury. History from a witness may be invaluable, and reversal of specific drugs with, for example, opioid antagonists is occasionally successful but should not delay intubation and supported mechanical ventilation in appropriate cases. Now, chronic and acute on chronic type 2 respiratory failure. The most common cause of chronic type 2 respiratory failure is severe COPD. Although partial pressure of arterial carbon dioxide may be persistently raised, there is no persisting acidemia because the kidneys retain bicarbonate, correcting arterial pH to normal. This compensated pattern, which may also occur in chronic neuromuscular disease or kyphoscoliosis, is maintained until there is a further acute illness, such as an exacerbation of COPD that precipitates an episode of acute on chronic respiratory failure, with acidemia and initial respiratory distress followed by drowsiness and eventually coma. These patients have lost their chemosensitivity to elevated partial pressure of arterial carbon dioxide, and so they may paradoxically depend on hypoxia for respiratory drive, and are at risk of respiratory depression if given high concentrations of oxygen. Example during ambulance transfers or in emergency departments. Moreover, in contrast to acute severe asthma, some patients with acute or chronic type 2 respiratory failure due to COPD may not appear distressed despite being critically ill with severe hypoxemia, hypercapnia, and acidemia. While the physical signs of carbon dioxide retention, that is delirium, flapping tremor, bounding pulses, and so on, can be helpful if present, they may not be, so measurement of arterial blood gases is mandatory in the assessment of initial severity and response to treatment. Management. The principal aims of treatment in acute or chronic type 2 respiratory failure are to achieve a safe partial pressure of arterial oxygen more than 7 kPa or 52 mm mercury without increasing partial pressure of arterial carbon dioxide and acidosis, while identifying and treating the precipitating condition. In these patients, it is not necessary to achieve a normal partial pressure of arterial oxygen. Even a small increase will greatly improve tissue oxygen delivery, since their partial pressure of arterial oxygen values are often on the steep part of the oxygen dissociation curve. The risk of worsening hypercapnia and coma must be balanced against those of severe hypoxemia, which include potentially fatal arrhythmias and hypoxic brain damage. Immediate treatment is shown in box 1717. Patients who are conscious and have adequate respiratory drive may benefit from non-invasive ventilation, NIV, which has been shown to reduce the need for intubation and shorten hospital stay in acidotic exacerbations of COPD. Patients who are drowsy and have low respiratory drive require an urgent decision regarding intubation and ventilation, as this is likely to be the only effective treatment, even though weaning off the ventilator may be difficult in severe disease. The decision is challenging, and important factors to consider include patient and family wishes, presence of a potentially remediable precipitating condition, prior functional capacity, and quality of life. The various types of non-invasive via a face mask or nasal mask, or invasive via an endotracheal tube ventilation are detailed on page 202. Respiratory stimulant drugs such as doxapram have been superseded by intubation and mechanical ventilation in patients with carbon dioxide narcosis. Home ventilation for chronic respiratory failure. NIV is of great value in the long-term treatment of respiratory failure due to spinal deformity, neuromuscular disease, and central alveolar hypoventilation. Some patients with advanced lung disease, example cystic fibrosis, also benefit from NIV for respiratory failure. In these conditions, type 2 respiratory failure can develop slowly and insidiously. Morning headache due to elevated partial pressure of arterial carbon dioxide and fatigue are common symptoms, but in many cases the diagnosis is revealed only by sleep studies or morning blood gas analysis. In the initial stages, ventilation is insufficient for metabolic needs only during sleep, when there is a physiological decline in ventilatory drive. Over time, however, carbon dioxide retention becomes chronic with renal compensation of acidosis. Treatment by home-based NIV overnight is often sufficient to restore the daytime partial pressure of carbon dioxide to normal and to relieve fatigue and headache. In advanced disease, example muscular dystrophies or cystic fibrosis, daytime NIV may also be required. Lung transplantation. Lung transplantation is an established treatment for carefully selected patients with advanced lung disease unresponsive to medical treatment. Single lung transplantation may be used for selected patients with advanced emphysema or lung fibrosis. This is contraindicated in patients with chronic bilateral pulmonary infection such as cystic fibrosis and bronchiectasis, because the transplanted lung is vulnerable to cross-infection in the context of post-transplant immunosuppression. And for these individuals, bilateral lung transplantation is the standard procedure. Combined heart-lung transplantation is still occasionally needed for patients with advanced congenital heart disease such as Eisenmenger syndrome, and is preferred by some surgeons for the treatment of primary pulmonary hypertension unresponsive to medical therapy. The prognosis following lung transplantation is improving steadily with modern immunosuppressive drugs. Over 50% 10-year survival in some UK centers. Chronic rejection with obliterative bronchiolitis continues to afflict some recipients. However, glucocorticoids are used to manage acute rejection, but drugs that inhibit cell-mediated immunity, especially such as cyclosporine, mycophenolate, and tacrolimus, are used to prevent chronic rejection. Azithromycin, statins, and total lymphoid irradiation are employed to treat obliterative bronchiolitis, but late organ failure remains a significant problem. The major factor limiting the availability of lung transplantation is the shortage of donor lungs. To improve organ availability, techniques to recondition the lungs in vitro after removal from the donor are being developed. Here is the indications for lung transplantation. This is subdivided into two groups: parenchymal lung disease and pulmonary vascular disease. For the parenchymal lung disease, the indications for lung transplantation is cystic fibrosis, emphysema, pulmonary fibrosis, obliterative bronchiolitis, Langerhans cell histiocytosis, lymphangioliomyomatosis. Pulmonary vasculature disease includes primary pulmonary hypertension, thromboembolic pulmonary hypertension, veno-occlusive disease, Eisenmenger syndrome. Now, assessment and management of acute and chronic type 2 respiratory failure. Initial assessment. Patient may not appear distressed despite being critically ill. Conscious level, response to commands, ability to cough, carbon dioxide retention, warm periphery, bounding pulses, flapping tremor. Airways obstruction, wheeze, prolonged expiration, hyperinflation, intercostal indrawing, pursed lips, cor pulmonale, peripheral edema, raised jugular venous pressure, hepatomegaly, ascites. Background functional status and quality of life. Signs of precipitating cause. Investigations. Arterial blood gases. Severity of hypoxemia, hypercapnia, acidemia, bicarbonate, chest X-ray. Management. Maintenance of airway. Treatment of specific precipitating cause. Frequent physiotherapy plus minus pharyngeal suction. Nebulized bronchodilators. Controlled oxygen therapy. Start with 24% Venturi mask. Aim for a partial pressure of arterial oxygen more than 7 kilopascal, that is 52 mm mercury. A partial pressure of arterial oxygen less than 5 or 37 mm mercury is dangerous. Antibiotics if evidence of infection. Diuretics if evidence of fluid overload. Progress. If partial pressure of arterial carbon dioxide continues to rise or a safe partial pressure of arterial oxygen cannot be achieved without severe hypercapnia and acidemia, mechanical ventilatory support may be required.